repair at the site of the site of root injury actually. So the double road hybrid repair, which is the variant for the types of tear, will be there where you will be going for double tunnel fixation to give a more secure fixation for the root. And root reconstruction using autograft, mainly Brasilis, which will be most commonly used if at all meniscal substance loss is there. So these are the main management options here. So for our patient, is there any role for conservative treatment? Obviously, it is not. It is no actually. So surgical reconstruction play a vital role in meniscal tear in especially younger and high demand knees, as in our case. And effect of associated ACL tear. Usually, the studies show that associated ACL tear will give a good functional outcome if the ACL has been repaired, and the meniscus will be having greater capacity to heal if at all is been repaired. So in our case, we have followed the following events actually. We have done our meniscal part first, and we have done a partial excision of the that loose meniscal fragment, that is posterior horn fragment, and we have gone for the horizontal mattress bite, and we have taken a root bite to reduce the extrusion, and we have prepared the single tunnel for the pull-out technique, and we have followed the ACL reconstruction in a standard manner. So I have a video here. So
just he has made, we are on the diagnosis. So anybody wants to raise his hand and just tell what we can do in this particular case? What should be the ideal treatment for this case? You can see the diagnostic video.
yes, sir, I'll pause. Sir. Yes. So yes, sir. So this is our case where you can appreciate actually. And this is a lateral meniscus tear where you can observe actually there is an oblique tear which is running from like lateral to medial, which is within a 1 centimeter of the root. So this is a part of lateral root tear, and it has also unstable posterior horn meniscal fragment also, which you can observe here. That is occasional clicks in the patient's symptoms. So I think dignitaries can answer the management options here.
Anybody wants to answer on your way of treating this patient? I think there is a lot of issue on that side. I would rather go for a repair intraarticular. This is 1 centimeter. That is what we are doing.
Yes, sir. That's oblique tear is within 1 centimeter actually.
It's like an oblique radial tear with a good fragment or a flap preserved on the root side. Yeah. So slightly more than a centimeter or almost centimeter.
Almost centimeter. That's running actually in the medial side.
Yes.
Okay.
It's a basically T shape of tear. One flap laterally and one flap centrally and
One
one
flap
flap
laterally.
laterally, and posterior also we have a meniscus tear.
Capsule was intact, sir,
Connect the
actually.
two flaps,
Okay.
which is anterior, side to side suture, and take some vertical stitch.
For
As
this
root
one.
is in. So there is no need to make tunnel.
Okay.
The lateral pattern which is there. It's loose. But it's attached to root.
No, sir. This is only the lateral aspect. This is lateral. The part is actually loose fragment. That is why mechanical symptoms are.
Actually, there are three fragments. One unstable fragment is there. One is unstable fragment. Then the good fragment is there, which is oblique. And the third fragment, which is
And it is not completely through and through, sir. It's not communicating to the capsule.
lines, different metal का अलग classification definitely 28 years old, only 2 months history I would have repaired because this is most about I would have repaired the two flats first, right? So that's this horizontal, vertical complex.
So horizontal matters.
Horizontal and then it becomes longitudinal. I would have repaired it to all inside the ACL.
How would you do this radial? Horizontal.
How do you fix this one, the part?
This one.
One flat is there also. The two flats anterior half of that posterior part, side to side, and then it becomes a longitudinal. विदाउट धूम सिंपल होगा,
हाँ सर,
विदाउट धूम सिंपल होगा।
नहीं वो लैपटॉप से ये हो रहा है, मतलब शेयर नहीं हो रहा है। हाँ
Good evening to all. I'm Dr. Laksh. I'm fellow under Dr. Mukesh Ladda, sir. I'm presenting a case. She's a 34-year female housewife. She had a history of trauma 2.5 years back and sustained a lateral TB plateau, which was fixed, range of motion and complete fracture healing. She now presented to us with the complaints of pain in knee while she was standing and walking, which was relieved at rest and which was aggravated since last 6 months. She had certain instability. There was no history of any locking sensation to her. On examination, there was no swelling. Tenderness was present on the medial joint line, and range of motion was 0 to 120 degrees. She had posterior DOR positive, posterior sag was present. Varus and valgus stress tests were negatives, dial tests were negative. There was no flexion deformity, and lifespan was also good. This was her gait.
Basically, just to show there was no lateral thrust and there was no virus. Pictures दिखा दो पीछे का,
Yes, sir. This was her clinical picture.
तो right knee.
She did not have any kind of flexion deformity. Okay. This was a just post-operative X-ray, which was fixed, and this was her current X-ray or when she presented to us. She had a posterior tibial slope of about 10 degrees, and medial joint line was reduced. So we diagnosed her as anterior anteromedial compartment osteoarthritis. Her MPTA was 90 and LDFA was 88. Miculis line was passing through the center of the knee. So we diagnosed her as anteromedial osteoarthritis with PCL insufficiency. This one, sir. Slope of 10 degrees and posterior sag of tibia was there. So Miculis line was passing through the center of the knee. It was an anteromedial osteoarthritis with PCL insufficiency. So what should we plan further?
I was done, but it was totally.
Implants was still there.
Implant was still there. So our diagnosis was medial joint was with PCL insufficiency. 34 years.
Medial joint also.
नहीं,
नहीं,
34.
34.
there is no virus. Joint अच्छा है.
वैसे intra-articular virus. Complete bone on
virus
bone.
नहीं है ना?
हाँ, but it's a bone on bone, intra-articular. Cartilage loss. Correctable virus. Intra-articular.
Flexion deformity वगैरह नहीं.
Nothing.
No FFD, nothing.
Virus नहीं है हमारा.
Clinical picture में भी नहीं है. Scan दिखा दे. You can see the limb.
MPTA 90, LDF 88.
Show Miculis.
हाँ ठीक है.
Tag was grade 3 plus.
But other than
Grade 3, very complete and corrected.
he made wearing X-ray.
Yes, sir.
Middle side pain. She's teacher by profession, getting difficulty in walking, class in Ghana, pain by class.
It's an anterior knee pain or medial pain?
Anteromedial theory.
Like patellofemoral symptoms है?
No, sir.
Grade 3 PCL.
Difficult to say over. She was like, sir, इधर भी दुख रहा है और उधर भी दुख रहा है. वो PCL था. Certain incident. Patient को poke किया तो बता दीजिए, otherwise pain was more under that. Immediate post of letter.
Okay.
Immediate post. This was immediate post of 2.5 years. अभी केस में नहीं.
Recent X-ray is not.
वो हटा सकते ही लोग. फ्रैगमेंट नहीं दिख रहा है. ना फ्रैगमेंट बोर्ड पे ही है. So we thought that we'll go with PCL implant removal and see what we can do for the withdrawal patients, and we will do some overcorrection each year to offload the medial compartment. We went with that process to patient which we are going to do PCL reconstruction, and we may do little extra of 4 to 5 years. We need to take it maximum up to 93, 94, 95. But when we went in, we had some very different picture. As you can see, grade 4 AMO almost complete, and medial. She had root tear also.
Middle meniscus.
I think missionary complete along with PCL.
PCL was also partial.
It was there, but and the reason for that injury was this chronic lock bucket handle lateral
Lateral
meniscus.
meniscus.
Since 2.5 years, there was no atrophic lesion. This was the lateral meniscus plaque, which was almost 2.5 years old over there.
Nice. That was
Spent
irreducible.
almost 15-20 minutes.
Nice.
No locking, no FFD, nothing. So that's the certain finding. We were trying to remove, and it was not at all. Since the certain fibers of ACL are still intact, it has become black because both sides.
Because clinical laxity, you won't not get much because of locking.
So now what? Patient को open mind से रेगुलर में अंदर डाल के decide करना सब क्या क्या करना.
Arthroscopy we got.
Lateral meniscectomy is a relative contraindication for STO because you will be loading the lateral side. So it's a relative contraindication. So if you take absolutely
Exactly.
Yeah.
and
Patient देख रहा था. The reducing of the work. I will still give a chance to though it was too old, I would expect that there are high chance of re-tear. If you medial compartment, but will reduce slow for normal.
subnormal NPT
Even when do we do the TCVO, we'll overcrowd the little compartment.
वीडियो lateral but for subluxation इसी में इसमें करके क्या करेंगे
तो एंटीरोमीडियल
इंडिकेशन है वीडियो lateral instability और it's a pagoda TBI दोनों में से कुछ भी नहीं
एंटीरोमीडियल arthritis.
Yeah, I think probably ACL with root repair.
We can offer.
और तुम UKR वगैरह कर रहे हो
34 annual. This hashtag you care about solutions. Below 50 saved them.
So
Really.
we used the neo ligament. Yes, sir. The dual ACL. We jacketed it over the peroneus longus tendon.
I thought this is the input indication because PCM sag होता है. Let's see. Result क्या है मुझे नहीं मालूम.
So we have studies of about 10 years, 10 to 20 years. That
The submission is सर्विस में ये यूज किया भैया सर्विस के क्वेश्चन में ये क्वेश्चन में कहां पे ये रेगुलर में यहाँ पे हमें पता नहीं ना क्वेश्चन में यूज किया हां उसने वही अंदर ग्राफ वही वो अच्छा है अंदर ग्राफ डाल और इतना वर्क करने
So this was our final picture. We reconstructed the PCL completely. The laxity of ACL also went off as the PCL was reconstructed. We did partial meniscectomy on the lateral meniscus, and we did a root repair for the medial meniscus. This
कुछ तो कार्टिलेज के लिए अभी तुम्हारा वो एक कम हो गया देखो एक्सरे This is only post अभी 2 हफ्ते ही हुआ. So I don't know about all you basically use this screw with the washer or only washer.
screw with washer, double fixation.
Always mistake that. You can nail it on double peroneus. So the diameter was 9.5. That graph will come out now. How you put through this double fixation? Graph under. बाकी का जो है I am just tracking that. नहीं screw डाला. The remaining graph will be outside. So graph outside.
That polyester dual ACL will remain outside.
You are using you cut it in even after putting the screw to drop both things. Usually the graph is longer. Jewel is longer, much longer. मालूम है नहीं jewel जो बाहर है. So I just what was the total length of peroneus? 11. 11 total double. That will definitely come out. नहीं I use inside out. तो ऊपर मैंने 25 डाला. 25 4 और 5 11 में just I understand. One more question. Can we reuse the well
Sir, what as per the brochure of that dual ACL, they have written that nahi sir, it have a length of 71 centimeters.
लेकिन उसका जो जैकेट पार्ट है जैकेट पार्ट इज स्मॉल.
Yes, sir. We can use it as a standalone if we want to.
It can be only as a tape, not as a jacket.
As a standalone. मतलब
not
हाँ.
the jacket. तो वीडियो में थोड़ा सा मन सेकंड मालूम नहीं.
Sir, brochure पे लिखा है not to be reused.
शेवर में भी लिखा तो शेवर में anything else anyone would have thought to do on table added something. अभी तो ये I would have added a section of osteotomy in this phase. Sound is actually neutral. 7 नहीं neutral. If this phase then osteotomy is the medial joint is open मतलब loading. You can see that the there OH is for the next speaker. हाँ तो फिर we can do a artificial
Slow increase कर लेते हैं नहीं I don't mean that slow increase करने
ECL का छोटा है, भारत भी है। I mean to say, Indo-Arctic का cartilage loss भी है। लोग तो ECL के लिए होगा।
This will be additionally
Virus will slow correction. Chronic For that, you have to break the reach and correct virus as well as the slope. But here, the slope was pure and she's only slope was we could have increased slope. The slope is much higher. If you increase the slope for S for ECL, it will have detrimental effect on ECL also because that will lead to more pressure on the slope. Slope was not. You increase your calculation. आप 16-17 तक एक लीजिए। Yeah, it's much higher than the pinch of salt.
not proof of primary correction of the slope. For revisions. Right, not revision, revision of the revision. Now they are doing it for revision. I was sitting on the case which ensured it in Hyderabad. Must have been the increase the slope और middle anti-rate को open करके slope को increase किया ideally थोड़ी that was the only posteriorly fixed ECBR. It is completely not correct. That's why
He can do it.
okay. Ensuring एक बार उसको question
No, Avian of humeral head, a twist in the tail. So this is there was a twist in the tail. It's not a standard avian. A 38-year-old IT professional was referred to me, pain and stiffness left shoulder since a few months. X-rays and MRI confirmed avian of the humeral head. The patient is a known case of sickle cell disease, and he has suffered from severe COVID and had taken the COVID vaccine. So there are some. So this is the left side is what we are looking at. As you can see, the forward flexion, abduction, external rotation, and internal rotation all restricted and painful. X-rays, classical avian, MRI scan. Now the MRI report threw up moderate to gross synovial effusion, and this was suspected as being superimposed infection, stroke osteomyelitis of the proximal humeral head. So I thought we should analyze this fluid. So we got a CT guided aspiration done. So the CT guided aspiration showed 7 ml of blood tinged yellow fluid, no organisms or AFB, no growth, but the NAT test for TB was detected. So it is like avian with sickle cell with tuberculosis. So now the present status is I referred him to a TB specialist physician who started him on anti-TB medication. His serum uric acid raised. Due to that, he got even more severe pain, started febuxostat, and then with only 3 weeks of anti-TB, his LFTs are now deranged. He's a very nice guy. He's got a little daughter, comes with his wife, IT professional. He came to me having been referred by another surgeon that you go have the operation done. So the plan was, before being referred to me, very simple. Go there, you have pain, have a operation on your, which will be a replacement type most likely, and then you'll be fine. And now that plan is totally gone. So he came prepared. He said, I don't have any issue with money or this thing. I said, that's not the issue. Here, the issue is not money or anything. It is just that what do we do? So, I suspect. Sickle cell disease, yeah, not great. Yeah. So now the questions that I have, I'm making the moderator's job easy. All the questions are here. The patient is fed up with the pain and is keen for surgery, but what should the surgery be, a surgical plan be, if at all? That is the main thing. Role of medical management. can we start it now? Medical management of AVN with anti-TB treatment going on. Timing or planning of surgery or optimization for surgery, surgical procedure or prosthesis. Which type of prosthesis? So these are the questions which I will have in my mind as we go along with in his treatment. So I thought I'll take your opinion because I don't have any decision in my mind yet. I thought I'll decide after I present this case. And he's a nice guy. He's thanked everyone that his case will be discussed here, and so some answers might come up.
Is he still on negative now?
AKT has been stopped because deranged LFTs.
So, alternate drugs.
Second regime, they are planning to start. They said we'll wait for a week and then we'll start consider a second regime.
Because you give under 3 weeks of AKT cover, you can do it.
Yes.
So same.
Yes, that is
Duration
well.
Not decreasing. Earlier it was 6 months, 3 months, now 3 weeks.
Yes, 3 weeks तक आ गया लेकिन मैं वही सोच रहा था कि if I had done this with that 3 week with anti-TB उसमें 6 to 12 months and then he ends up with this liver function test derange and you have to stop the anti-TB. So those things.
Hemolytic anemia also has
liver function. So he is a complex case. So that's why I presented in the Arthroscopy Society because I was thinking, is there an easier way to get out, like arthroscopic washout with maybe BMAC or something? I'm just throwing this to all of you. I'm not saying whether it will work or not, but is there a smaller procedure with anti-TB with medical management of AVN? Because I'm in a few AVN groups. I don't have that much experience of AVN. Having been in UK, yes. Yes.
The most cold decompression.
That's what I was thinking.
Actually, it has collapsed. It is beyond the collapse.
I mean, this chap in some orthopedic surgeon, Dr. Karne in Nasik or somewhere, he does a lot of BMAX for AVN and he claims he's done 165 with very good results. So
The staging might not be this bad. See, there's a thin flap of
yes,
flap.
yes, very thin flap, yeah, yes, exactly.
The third pillar.
Yes, yes,
Actually,
exactly.
it's just
It's waiting to chip off. Yeah, it's like an eggshell.
Yes,
So,
and I think that is the reason for severe.
that could be.
In that section, you can see the collapse also.
The collapse is also
There is collapse.
It's just
The radiological collapse.
Haan,
X-ray
right.
wise.
Yes.
Smaller submission, he is having hepatotoxicity due to the ATD.
Right.
So he can be given with the guiding sparing, like uric acid, levofloxacin, and
Yes, yes.
combination.
Yes.
For some days, it usually takes 10 odd days to reduce the raised enzymes, and after that, gradually starting on with the ATD management.
Okay.
You will, the enzymes will not raise that much.
Okay.
And you can take a decision afterwards, like debridement or something
Mhm.
after a gap of 3-4 weeks.
Yeah. I feel that tuberculous burden somehow, if it can be, reduced, and whether the other option is just starting medical management. I don't know how convincing it is. There is Agrawala regime, there is this Mukherjee regime. Everybody has come up with their own regime. But Dr. Mukherjee from Delhi claims of thousands of patients. Agrawala, Vijay Bose says he's treated thousands of patients. Bisphosphonate, yeah. So I checked. Bisphosphonates, teriparatide, denosumab, these do not have any kind of adverse effects with anti-TB. So that I checked. They don't clash with anti-TB. In fact, denosumab has been used for some cases. And then they, in that, whether to add some Medrol or steroid, prednisolone oral for the pain. Denosumab.
I think bisphosphonate and ecosprin.
Ecosprin, bisphosphonate. Teriparatide.
You can have no personal experience, but now literature is coming up. They can use it for AVN.
Yeah.
But I think that post-COVID, this is sickle cell. Whatever we give, it's going to.
That's
Because
also,
we
we
have
don't know.
COVID-
That was a good,
because
that's a
sickle
good
cell-
question. Yes, yes, that's a good question. I don't know.
If it had been only a COVID-induced or
Yes, yes.
steroid-induced, then
Hmm.
this regime would have worked very well.
Yes,
Whatever you do.
true.
But here you haven't,
Hmm.
the bone impact is so big.
Even in
Hmm.
COVID, they have not worked that well.
Hmm.
The isolated idiopathic avian,
Hmm.
all those things are working well. But
Hmm.
even in COVID,
COVID, they have not worked.
collapse was much earlier.
Okay.
I think all this.
Is there any way we can say that this is because of sickle cell, not COVID? With surety.
I think the kind of bone impact which is seen.
Which is more probable? Sickle cell.
Sickle cell is rural area.
But he's had sickle cell for 15 years. But it can develop anytime, I know. And this happened post-COVID. I know.
How was his response after 3 weeks of AKG symptoms?
Symptom-wise, he's such an unfortunate guy. His serum acid, uric acid raised. So he started getting more pain. But his other symptoms like indolent fever and all, they settled down after anti-TB. Yeah. He used to have this fever and all those.
What your TB specialist told after you developed this?
He said we'll stop it for 10 days.
Second line, what?
Second line, he said that after 10 days, we'll repeat the LFTs and then decide the second line that you said, which is LFT sparing or enzyme sparing. I don't know what drugs are there, to be honest, but they will know.
So now it is on second line, and is controlled well.
Hmm.
So after second line, 1 month is compatible. What is your surgical plan?
If he is comfortable,
Under AKT cover, all his parameters are normal.
hmm,
So what do you plan for it?
I think I cannot save the humoral head. That's one thing. And TB, once he is comfortable with the TB, then we can plan surgery. With that will be active TB surgery, because a lot of papers are on quiescent TB, which happened 10 years ago, hip. Most of the data is from hip.
At the surgery, yeah, interested to know what the surgery
Yes, yes, yes.
Plus his age is around 40. That is
38, yeah.
But
that is the
how will you
average
relieve
life
how will you relieve the pain other than surgery?
Any other morning lesions?
Bony.
Or other
No, no,
surgery?
no.
Infarcts?
No other bone.
It won't relieve because the pain is for 8 weeks.
So it's basically not now, and the treatment is a joint replacement.
Exactly, yeah. Absolutely. I mean, because the glenoid side in avian is okay, and why in shoulder touch it? Glenoid, we don't need to touch it, especially with sickle cell. There's no point in increasing the surgical insult. But still, because of all his problems, I thought best is to refer. Kar do refer. I thought I'll manage him medically and then. And simply because you start one thing, red flag. That's exactly. Exactly. Surgical में anesthesia issue, you said sickle cell crisis. उसके बाद टीबी को फिर से अगर वो इंटॉलरेंट हो गया और इन्फेक्शन आ गया तो यानी it is it's a very high.
He's a good guy, but high.
Very high risk. So my plan was start anti-TB, start whatever medical management of avian is, and see with time, try to delay surgery by time, and then see in 2-3 months time what happens.
So I would repeat that TB test. Too many diseases in one person is usually.
Yeah, you're right.
Do that.
They often say that, yeah, 2 or 3 diseases, more than 2 serious diseases are.
Because of axis pattern of.
But this NAT test apparently is quite this thing.
Tejas is online, he's waiting.
So your plan will be like maybe.
Yes.
Down surgical.
Yes. And then, no, not stemless. Short stem or long stem, preferably long stem if I'm going once there, because I don't want any problems later on to come in his case. a standard long stem hemi, uncemented.
Tejas from Bakola in online is just. Dr. Tejas.
Am I audible? Am I audible?
So, you can start, sir.
Okay.
Can you hear us? Can you hear us?
Yeah. So can you see the screen, please? Is the screen visible? Is the screen visible for y'all? Can I have a audio feedback from anyone?
Yeah, sir, your voice is actually not very loud. Not audible.
Am I audible or am I not audible?
Not audible.
Hello. Is the voice audible or it's not? Hello. 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 Yeah, am I audible? Dr. Amit?
Yes, yes, you are audible.
I'm audible. Okay. So, first of all, आप सभी को हनुमान जयंती की शुभकामनाएं. And I present this case of a 49-year-old female who was diabetic. She was right hand dominant and she had severe left-sided shoulder pain. These are her X-rays. Anyone would care to diagnose this radiographically?
नहीं ये नहीं करना yeah Tejas,
Yeah.
seems to be an calcification in supraspinatus tendon insertion.
Yeah.
Let me call it a calcific tendinitis.
All right. So this patient had a history of a subacromial, an injection given by another orthopedic surgeon, and she developed an acute flare pain. So if this is calcific tendinitis, presuming this is calcific tendinitis, what are the causes for this acute flare?
Is she yeah, she is diabetic.
Yes.
Yeah. Tejas, Mukesh.
Yeah, Mukesh.
Calcific tendinitis itself causes severe pain and pseudoparalytic kind of picture.
Okay.
Now you're saying she already had an injection in it and she is diabetic. And
Yeah.
after injection, her pain increased.
Yeah.
So immediately or after a couple of days or after 5-7 days, a week or two, or how it is?
Right. So when she came to us, we did a hematological profile. We just wanted to be absolutely sure that there is no secondary infection. And just before we go through the other stage, the other part, let's talk about what are the theories for this calcific tendinitis. So the calcific tendinitis, there are two theories which are determined. one is degenerative, and the commonest accepted theory is the one by Utkoff and Luer way back in 1997. They described it as a reactive calcification. And they have described it into 3 stages, which is the pre-calcific stage, the calcific stage, and the post-calcific stage. However, what is important for us to remember is that the resorptive phase of the calcific stage is the one which is most painful. Now here, the calcific deposits tend to be absorbed by phagocytosis. So if you look at the slide, the cause of pain is bursitis, inflammatory synovitis, the chemical furuncles which cause swelling and an increased local pressure, and thickening of the bursa. Now one thing that we did not discuss, or rather I was not asked about, is the clinical examination. So let's look at the clinical examination. You can see that the supraspinatus insertion is tender, but what is more tender is something more medially. Can everyone appreciate that?
Repeat.
So let's look at the video again. The supraspinatus, the Codman's point is tender. However, something more medially is tender.
Seems to be biceps talus very long of biceps tendons.
The biceps tendon is a little more laterally. This was just, and of course, like Mukesh said, the patient had severe pain and there was pseudo paralysis. So the patient had pain more not on the supraspinatus tendon insertion, but it was more medially. Now let's look at the MRI scan which was ordered.
So it goes on
Anything
insertion
that
of
anyone would
subscap.
like to comment on the MRI scan?
Subscap tendon muscle, it seems to be a little bit inflamed.
Right.
Other sections, can we say, supraspinatus seems to be quite okay. Subacromial space is also quite good. Mainly
Right. So exactly as rightly pointed out, in fact, this was not a supraspinatus tendinitis calcification. This was a calcific bursitis. As you can see, the rotator cuff appears normal. However, there is intense inflammation in the bursal tissue. So the learning point from this is, one, a good clinical examination to know what your patient suffers from. And once we go back to the X-rays, the calcification is superior to the GT. And generally, the calcific tendinitis patients, or rather the calcification which is in the supraspinatus, will be 1 to 1.5 centimeters medial to the GT. Here, the calcification is exactly superior to the GT. So these 2-3 things tell us, and the patient had an injection. So what the injection might have done is probably take the calcium out and deposit it into the subacromial region and cause this severe inflammatory cascaded reaction. Of course, it is also possible that there could be other multiple factors or variables. Now, looking at this, I opted for surgical management for this patient. I told the patient I'll do a arthroscopy and we'll try to remove the calcification and the inflammatory tissue. Another look at the relevant MRI images show that the supraspinatus is normal. This was a calcific bursitis. Just another image which I have taken from the internet just to compare, where you can see at a calcific tendinitis, the calcium is deposited inside the tendon and not outside it. Now the surgery was pretty straightforward. It is just a subacromial decompression and removal of the bursa and removal of the calcium. There was some synovitis intra-articularly as well. And
sorry to interrupt.
was derided. Yeah.
Did you think of doing a ultrasound guided needling or conservative management here?
Yeah, so there are 2-3 options. There are different ways to bell this cat. No one option is like, if you look at the literature, before going ahead with this surgery, I went through literature, and there are certain reports where ultrasound guided Babutaji has led to calcific bursitis. There are also papers where they say that a repeat barbotage with an ultrasound guided is an option. However, for me, in my hands, I thought that I could do an arthroscopic job for her and probably give her a reasonable result. However, yes, you are absolutely right. You can do an ultrasound, or you can also do a repeat injection after negating out infection. That's what we did. We did her CRP levels. We did her ESR, which were not raised. And since she was a diabetic, I thought that this would be a better option in my hands. So coming back to the video, that's what was done. There was some synovitis. We removed intra-articularly. And once we went in the subacromial region, there was significant bursa. Again, the same thing, combination of radiofrequency ablators and shaver was used. This case was done way back in 2021 during the COVID times. Surprisingly, since Sahani sir was talking about COVID, I just thought that I would share that. And as you can see, the tendon did not have a lot of calcification. In fact, it was all outside. And we managed to clear it. Of course, we intraoperatively, always with these kind of patients, we look at the CM images to see that we have completely removed the calcification. And that's what we were able to do. That's the post-operative X-ray after, I think, immediate post-operative X-ray. And this was the patient when she was last recorded.
Yes.
And see that her pain around the Codman's insertion area, the long head biceps, as well as the place where she was tender was not there. The patient's impingement signs had gone, and paralysis also started improving, and he gradually gained range of movement. We also had another review for at 2 years follow, but unfortunately I could not find that video. But you have to trust me on the fact that she has sent me patients and she is doing quite well now with a 4-year follow-up. So from this small talk, what I wanted to share with each and everyone, especially my younger colleagues who are seeing this talk, is that clinical examination is a key, especially not every calcification around the shoulder will be calcific tendinitis, and it might be something else as well. And if we keep an open mind and different options available for us, we can still cure these patients. Thank you.
Thank you, Dr. Tejas. That was a nice case presentation, and we have learned a lot. Like first, we should always do the clinical examination, then go for the other modalities of investigation. Any question? I'll just make one comment about ultrasound guided barbotage because I have tremendous experience with it, Tejas. I don't personally, because this was done by my radiologist, Dr. Sumit Ranteke. He is a brilliant expert in Manchester. Okay. Almost like 20 in a month, these calcific tendinitis, because he covers 4 hospitals. So his results are brilliant with ultrasound guided barbotage. The advantage is being it's done in the local anesthetic in the outpatient setting. And his criteria, cutoff criteria, Tejas, is 1 centimeter. And more than 1 centimeter, he doesn't do it. If the calcific load. And usually not as dense as yours. Yours was very dense. So when there is cloudy calcification, then you are able to remove it much easier with barbotage. So I think the decision of arthroscopic excision was the right one. But then for the new surgeons, the problem is to find the calcific this thing, you know. The needle marking technique, put PDS, go from top, bottom. But the way to find it, I have seen whenever I've done arthroscopy for a lot of for these calcific tendinitis is there is a small area of inflammation where the calcium is. So that gets away, and if you put a needle and withdraw it, put the scope from the joint side, needle from the top into the rotator cuff, the supraspinatus coming into the joint, and there you can see the mouth of the needle full with calcium. And then you put a PDS suture through it and remove the needle, and now your suture is a marker. Go from the subacromial space and if the vein is slit 3 millimeter and remove it. Because you don't want to damage the cuff. That's the main thing.
Yeah, those are very, very, very important and very interesting points. Sure. Thank you, sir.
Hi, Tejas, Naved here.
Yeah, hi, Navid, I can see you.
Yeah, okay. So, Tejas, you must have read a lot. Can you just let us know the option of extracorporeal shock wave?
Hello. Hello. Voice is cut. Hello. Yeah, I can hear you. Okay, I can hear it here as well now. Looks like I can see the videos.
Okay,
Yeah,
so next time we'll do it like this.
sure. I think the first thing which you said that I have read a lot, so I think you presumed it wrong. I don't read a lot. So probably talking about ESWTs, like you asked me about ESWTs, right? So ESWTs, I have never done it personally. However, during my fellowship training, I've seen it being done. And of course, hello.
Yeah, we can hear you, Tejas.
Yeah. So I don't have any experience now in my private practice, but during fellowship, I have seen ESWTs being done, and definitely in terms of literature, if you look at it, all the options, like anything in orthopedics, everything is controversial, including the theories of calcific tendinitis. So probably, I think it is horses for courses approach. What works in your hands and what kind of infrastructure you have, and as well and also what kind of training that like your radiologists have. If radiologist or you have the training, then probably even an ESWT is a good option, or an ultrasound guided Babutaji. However, for maximum amount of my patients, subacromial injections also work. The voice is, someone needs to unmute the podium voice, please.
Can you hear us, Dr. Tejas?
Yes, Jain sir.
Yes. Thank you. That was a nice presentation. So from now we can wind up this meeting. And
thank you very much.
Thank you for all presenters. We have a prize for the best presentation today. And absolutely, you're right. I've taken many last time. देखो इसको दिखा तुमको तेजस सर का नहीं इन्वॉल्व रहेगा ना इसमें नहीं सर
Next time जहाँ जाएगा.
Okay, I think all of them presented very well. Dr. Tejas was online with us and he presented on Kelsbeck tendinitis. What an excellent presentation. And I think it's difficult to decide. All of them did a very good presentation. So, but for the sake of presentation, इसको लॉक किया जाए. I think Dr. Suhas Aradhya, who presented complex lateral meniscus fracture. Congratulations. So on behalf of ASN and the clinical committee, I would like to thank Dr. Siddharth and Dr. Amit for moderating this today's session. Please come forward. And so I think, yeah, we need more attendance today. It looks like the residents are more than the surgeons over here. So that's good, but we need more attendance next time. So all of you, please present cases. It will be good for you as presenters. You know how to present, and your career will shine with this. So with that, we can start with dinner. Any suggestions for improvement to the clinical committee are most welcome. अगर आप अभी नहीं बोल सकते हैं तो बाद में बोलिए, कोई दिक्कत नहीं. Yeah, you can. And I would request the residents to get apply for the life membership of ASN, and so that you can avail all the benefits of the membership. Yeah. Thank you. Meeting, anyone can talk. For the meeting, that's not a problem. Good.